topic, that's viral infections in the ICU. Most of the times we would talk a lot about other things, bacterial and fungal infections, but very little is talked about the viral infections. They do result in a lot of morbidity and mortality, not only in the ICU, outside ICU as well. The objective of my talk is to describe the common viral infections which present in the ICU, to give an overview of these infections, to discuss the presentation and management of respiratory viral infections, to give an overview of viruses causing neural and hemorrhagic manifestation. And in the end, I'll discuss about the very common organism now seen, particularly the rise in the transplants, the cytomegalovirus. I will talk in the end, and I'll also discuss about its management. The viral infections in the ICU, predominantly I think the respiratory viruses. These are the commonest viruses because of which a person comes in the ICU. Neurological viral infections, the gastrointestinal viral infections, virus-related shock and hemorrhagic fever, and of course the viruses causing infection in the immunocompromised host. That's also extremely common, by which a patient presents in the ICU. Actually, if you see, the ICU were made because of the virus diseases. In 1952, an outbreak of poliomyelitis occurred in Denmark, and as you see, the lot of negative pressure ventilators, and the intensive care unit actually started with a virus. Because of poliovirus, the ICU were created, and then they were prevalent all over the world. The majority of viral infections that require ICU care involve the respiratory tract or the CNS. Other organ systems such as GIT or heart may also be affected. As I already discussed, the reported incidence of viral infections in the ICU varies widely across studies and geographic regions. Improved molecular detection has really made the difference, particularly the PCR now have changed the epidemiology of viral infections. We are detecting more and more of virus infections, and we have better idea about the epidemiology of viral infections. Let's first talk about the commonest infection, that's the viral infections. The respiratory viral infection could be exogenous influenza A, including H1N1, H5N1, and influenza B, respiratory syncytial virus, parainfluenza virus, adenovirus, metapneumovirus, coronavirus, and the rhinovirus. And then the viruses which are present in many of the populations, they are the cytomegalo, herpes simplex, varicella zoster virus. These infections get reactivated when a person becomes immunosuppressive or immunocompromised. They can also get activated in immunocompetent patients when they land in the ICU for a long time. The community acquired pneumonia is usually caused by bacteria, but viruses do constitute about 3 to 10% of cases in large series. And of course, the commonest organism to cause the pneumonia due to viruses is the influenza A and B viruses. And immunocompromised patients, they get community acquired pneumonia because of the when there is a reactivation of viruses, or particularly they get infection because of RSV, cytomegalovirus, herpes simplex, varicella zoster, and adenovirus. These are the common infections which are seen in immunocompromised patient. Viral pneumonias can be nosocomial acquired. I mean, you can see the viral pneumonia in a person who has been admitted in the ICU, is on a ventilator. And there are studies, particularly this recent study, which showed that 34% of the 134 patients of the healthcare associated pneumonia had at least one respiratory virus recovered from the nasopharyngeal swab or the lower respiratory tract. Recent studies have shown that 22.5 to 34% of patients in the ICU with healthcare associated pneumonia had one or more respiratory viruses in the lower respiratory tract, which was seen in the bronchoalveolar lavage or the endotracheal aspirates. You know, one of the other thing which is seen in the intensive care is the isolation of the herpes simplex virus and the cytomegalovirus. When a person has been staying in the ICU for a long time, in many of these patients you isolate HSV and CMV. Whether they are responsible for causing infections or a disease, it's really not very clear. But there are certain facts which have come into light which also tell you that probably they could be responsible, like the confirmed HIV cases in patients of ARDS have longer period of ventilator and hospital stay. CMV detected in blood after 10 days stay in the ICU, and these patients had pneumonia seen after 3 weeks on a ventilator. HSV or CMV detection in bowel fluid does not necessarily mean that viral VAP. This is another thing, that it may be responsible, it may not be responsible. It may be just that they get reactivated during a period when a person gets a little bit immune compromised because of the disease, because of being ventilator, because of being in the ICU for a long time, and there is a replication of the viruses like HSV and the cytomegalovirus. You isolate them, they may not be responsible for disease, but in certain individuals they may be responsible. And I think we need more RCTs to really know whether they are responsible for causing infection or not. They have also seen that if you get HSV viral load more than 1 lakh copies or 100,000 copies in bowel fluid, they have a poor prognosis. Similarly, CMV viral load of more than 1,000 copies by real-time PCR was also associated with increased mortality or prolonged ICU stay. So we need more studies to really find out the significance of the CMV and the HSV in their role in the healthcare associated pneumonia. Then the respiratory viruses, they can present a simple illness or they can present a very severe illness like hypoxemic respiratory failure. Of course, the influenza is the commonest, but the other organism like RSV, the severe acute respiratory syndrome, Middle East respiratory syndrome, coronavirus, adenovirus, cytomegalovirus, HSV, parainfluenza, petapneumovirus, all these have been associated with causing hypoxemic respiratory failure. And ventilator associated pneumonia, as I said, HSV, CMV and Mimi virus has been implicated or has been associated with the hypoxemic respiratory failure. Then in certain individuals like asthma and COPD, when they get a viral infection, they can develop a hypercapnic respiratory failure along with association of hypoxemia. And the organism which commonly are isolated in these: influenza A, B, coronavirus, rhinovirus, parainfluenza 1 and 4, and respiratory syncytial viruses A and B. Then I will discuss in detail about a very, very common viral infection, and that is influenza. Influenza has 3 types: influenza A, influenza B and influenza C. There are subtypes which are based on the surface glycoprotein like hemagglutinin H and neuraminidase N, and that's why you see a lot of number H1N1, H7, N7 like that. The current subtype which are commonly causing infections are the influenza A viruses, H1N1 and H3N2 viruses, influenza A. You also see the influenza B viruses which cause infections. H3N2 causes a greatest morbidity and mortality. H1N1 and influenza B virus and H3N2 are included in the influenza vaccine. So all these 3, the strain may be different every year, but these 3 are included in the influenza vaccine. Then it is important to understand why we keep on getting the season flu or why we get a pandemic. You know, when there is a small variation in the antigen of the virus, you get an epidemic or a season flu. When there is a large variation in the antigen of influenza virus, you get a pandemic. The influenza A has been associated with the pandemics. Influenza B virus usually causes only the seasonal and you only see the antigenic drift in these patients. Then as I said earlier, that influenza A and B virus, they cause acute respiratory illness, outbreaks and epidemics mainly in the winter seasons. So let me a little bit talk about that. There is a renewed interest about the influenza virus in last about 4 to 5 years. This is basically because of the H1N1 pandemic which occurred in 2009. First case was reported in Mexico mid-April 2009 when there was little or no immunity in population. There was a antigenic shift. There widespread cases were reported in 241 countries all over the world, and WHO had declared pandemic in June 2009. There were a lot of cases published, a lot of series were published and papers which showed that in New England Journal of Medicine, one of the paper which was published showed that the 2,155 cases in only 35 days they reported, and 100 people had died, and there was death reported in other various studies from all over the world. Now we have controlled H1N virus, but the pandemic is of course over, but this H1N virus continues to circulate seasonally worldwide, and you do cases which can be in a large number or in a small numbers in most of the countries. The transmission of this virus occurs from person to person. It is infectious 24 hours before symptoms and 5 to 7 days after the symptom onset. It spreads by droplet transmission, the large respiratory droplet, which can spread up to 3 to 6 feet, and person is infective 24 hours before and 5 to 7 days after getting the illness. It's spread by contact transmission as well, like computers, by direct contamination with the contaminated surface, then you touch eyes, nose and mouth, and the infection spread into you. The incubation period is about 1.5 to 3 days, but it can varies up to 7 days. Children, severely ill person and those with weakened symptoms may shed virus for a longer time. Even people have seen up to 2 to 3 weeks, but normally about 7 days the shedding should disappear. Flu season varies substantially from year to year, so it is difficult to predict severity or timing when the season flu will occur. Now I think it is also important when to call that person has an infection or it is an influenza-like illness. When a person has just fever with cough or sore throat in the absence of known cause other than influenza, you call it influenza-like illness. The clinical findings or the clinical presentations of influenza is it could be simple flu, like a patient who has got a fever plus some respiratory symptom. It can present as a primary viral pneumonia. It can go on to develop respiratory failure, ARDS. It can have a secondary bacterial pneumonia, and children may have an unusual presentation like febrile seizures, transverse myelitis, myocarditis and encephalopathy. The signs and symptoms are like any other influenza infection, like fever in 93% and cough 83%, then headache, wheezing, malaise, and some patients may present with GIT symptoms like vomiting and diarrhea. There are certain group of patients who are at increased risk of getting severe influenza. Children younger than 5, particularly less than 2 years, adults 65 years of age and older, pregnant women, and there are certain diseases which are also the patients are at increased risk of getting a severe infection, like asthma, neurological and neurodevelopmental condition, chronic lung diseases, heart diseases, blood disorders, endocrine disorders, then patient having kidney and liver disorders, metabolic disorders, people younger than 19 years of age who are on aspirin, people who are morbid obese, people who are obese, particularly with a BMI of more than 40, they are at increased risk of getting a severe influenza infection. The radiology in these patients, they may have infiltrates or they may have minimal infiltrates which can spread all over the lung, and chest radiograph or the CT scan may show patchy consolidation, ground glassing, and predominantly the lesions are at the periphery and the parahilar. The complication of influenza, most of the times when it is a severe infection, the respiratory single organ failure is the commonest presentation. Most of the patients will have a severe respiratory failure, can go on to develop severe ARDS, but may not have the involvement of the other organs. And but when the time passes, many of them, or because of secondary infection, they can develop a multi-organ failure. Mortality is high if you are not able to manage these severe hypoxemia or the multi-organ failure. The bacterial superinfection occurs in 4 to 29% of patients who develop the influenza infections. People who die, they have seen that they had alveolar hemorrhage and the viral infection was lining the alveolar cells. Knows these patients. There is a rapid antigen immunofluorescent antibody tests are available, but they are not that commonly used. And after the introduction of the RT-PCR or the molecular based assays, it has really made the difference in the diagnosis of influenza, particularly the H1N1 infections. The RT-PCR can be done on a sample, a nasopharyngeal swab, or a nasal aspirate, or endotracheal aspirates, or a bronchoalveolar lavage. You can do a RT-PCR test to diagnose a H1N1 or any influenza virus for which the RT-PCR is available. Viral culture is routinely not recommended because it takes more time and you have to take action quickly in these patients. Now let's talk about the treatment of these patients. It is extremely important to initiate the antiviral therapy as early as possible and without waiting for the lab reports. It is given to children, adolescents or adults with suspected or confirmed influenza infection if they have one of the following features. What I am trying to say is that you don't give antiviral because you isolated influenza or any H1N1. You only give antiviral if a person has some of the features which require that person should be given antiviral, like an illness requiring hospitalization, progressive, severe or complicated illness regardless of the previous health status. Then patient less than 5 or particularly less than 2 years, adults more than 65, pregnant women, severely immunosuppressed patients, morbid obese patient with a BMI of more than 40 and individuals with certain medical conditions which I had enumerated, you should give antiviral therapy if they develop the H1N1 or any other influenza infection which requires the antiviral treatment. So what are the drugs available? I think there are two kind of drugs, but neuraminidase inhibitor oseltamivir is the commonest drug in this group, which has been used extensively and it has been found to be effective. And the other drug is inhaled zanamivir, which can also be used in these patients. The dosages of oseltamivir 75 milligram is given twice per day for 5 days. In a serious patient, you give 150 milligram twice a day for 5 days is the usual duration, but it can be given for a prolonged period in a very severe patient. Similarly, in children it is given according to the body weight. The zanamivir is given in the inhalation form 10 milligram to 5 milligram inhalation twice a day is given, and children you give again the 5 mg inhalation twice a day. For the prophylaxis it is only given once daily. There is evidence that the antiviral treatment is effective in H1N1 infections. This is a study in 657 patients where they showed that if the oseltamivir was given within 48 hours of onset of the symptoms, they had a lower mortality than if a person was given after that. Similarly, in children, they saw in Spain that in pandemic H1N1 infection, those where the oseltamivir was delayed for more than 72 hours following the onset of symptoms, the mortality was higher. Similarly, in pregnancy, they showed that if the antiviral treatment was given within 4 days, the mortality was less as compared to 4 days after the onset of symptoms. So it is important not only to give the antiviral treatment, but also to give early because you can prevent the severe infections and mortality in these patients. The basic benefit of giving antiviral treatment is the decrease in the severity of viral illness. Drug resistance has also been reported, and the vast majority of strains are sensitive to oseltamivir and zanamivir, but all strains are resistant to amantadine and rimantadine. The other thing, in addition to the antiviral treatment in the management of H1 infection, is the care of these patients, because they can spread to another patient. So there are special kind of masks which are made, which should be used if available, for giving oxygenation and the aerosols to these patients. If a patient develops respiratory failure only for mild ARDS, you should give non-invasive ventilation. And moderate and severe ARDS, you should give the invasive ventilation. The invasive ventilatory support is required if a person is not responding to oxygenation, the sp2 is less than 90% on a 50 liters oxygen flow, respiratory acidosis, pH is less than 7.2, there is a patient is having a very high respiratory rate, like more than 40s, and respiratory distress, it is very difficult to sustain such a high rate, and patient who cannot protect his airways or has got a moderate or severe ARDS, these patients should be ventilated and should be given the invasive ventilation. Then the setup in these patients should be based, when you ventilate these, as per the ARDS net protocol. You should give them a low tidal volume, 6 ml per kg of predicted body weight, and keep the plateau pressure below 30 centimeter of water at all times. There are some specific precaution you should use when you ventilate these patients. Current ventilatory setup is appropriate, including tubing, humidifications, bacteria, viral filters on the expiratory circuit. That's okay. Change of tubing should also be done as per the current practices, but the close suctioning is preferred. You should not use open, and you should not break the circuit too often, because it can spread the viruses to the people who are present around it. If circuit has to be broken, adopt aerosol generating procedure precautions so that it doesn't spread to the healthcare givers. Then these patients are also prone to develop refractory hypoxemia, and they may not respond to the usual mechanical ventilation. So refractory hypoxemia is managed as per the protocol in your hospital, like you do a proning, you can give a high frequency ventilation if you have the availability, and you could also use APRV in these patients. But I think ECMO in a patient who is not responding to the prone positioning and to the usual management, ECMO has been introduced early in these patients, and they have seen that it improves survival in these patients. Then these patients are prone to develop secondary bacterial infections. So you give them antibiotics if there is a sign of infections, and if in a seriously ill patient, because Streptococcus pneumoniae and Staph aureus are the commonest organism. So patients who are at a risk of developing secondary infection, one should give these antibiotics. The other thing is the healthcare should protect themselves from these infections, and the healthcare givers should wear the N95 mask when they are taking care of such patients, and these patients have to be admitted in isolation. There is no need of putting these patients outside your ICU, but ideally it should be, if it has been diagnosed, you put in a single room and take the usual precaution to prevent the spread of infection to the healthcare workers and in your ICU. Now I'll talk about the other respiratory viruses which have resulted in increased morbidity and mortality. Avian influenza is one of the viruses which was first reported in 1997, then in 2003, and then 2012 and 13, where a lot of cases of avian influenza were reported. H5N1 was the first one, and 2012 and 13, H7N9 was the influenza virus which was reported, which resulted in increased mortality in these patients. and of course the oseltamivir was the drug which was used in these patients and found to be effective. SARS you must have heard about, which is a coronavirus, in winter of 2002, and this was discovered in China. Disease spread due to traveling, it spread many part of the world. Animal reservoir may be bats, and it starts with high fever, cough, and then result in a respiratory failure, and it also reported very high mortality. Then MERS, or the Middle East Respiratory Syndrome, is another virus which has been reported in Saudi Arabia in 2012, and so far all cases have been reported in the Arabian Peninsula. It's highly infectious, peaks in winter, incubation period is 2 to 4. The virus spreads from ill people to others, though close contact such as caring or living with an infected persons. However, there is no evidence of sustained spread in the community settings. And the evidence is also that it can be acquired by close contact with the close contacts and the animals. The clinical feature is a severe acute respiratory illness. They can fever, cough, shortness of breath. Some people have gastrointestinal symptoms like diarrhea, nausea and vomiting, and some people may have very mild symptoms. The complication is pneumonia and kidney failure. 30% of the people in the Middle East respiratory syndrome or the coronavirus, almost 30% of the patient died. Most of the patient who died had an underlying medical condition such as diabetes, cancer, chronic lung, heart and kidney disease, and more likely to be infected with MERS or have a severe case. Individual with weak immune system are also at a high risk of getting this Middle East respiratory syndrome coronavirus. Then treatment of SARS and MERS is usually, it is only supportive treatment, meticulous supporting and intensive care. During epidemics, they have given high dose glucocorticoids and ribavirin, but most experts now agree that neither treatment had a clear benefit effect. Lopinavir and ritonavir may have some effectivity against the viruses, but its efficacy has still not been established. Then in general about the viral infections, the viral respiratory infections, acyclovir has been given for varicella zoster virus pneumonitis. It has a limited efficacy. It's widely recommended as an early primary therapy. Canciclovir for CMV pneumonitis, particularly in solid lung transplant patients, has shown to decrease morbidity. So this drug could be tried in a CMV pneumonitis. Steroids, they reduce the inflammation tissue injury in SARS and VZV pneumonitis, but they have also shown limited proven efficacy in these individuals. The immunotherapy has been tried in RSV infection in the pediatric group, like the pelvizumab is approved for high-risk pediatric patients who have the RSV infections. IVIG has been given to patients who have respiratory viruses and have developed Guillain-Barré syndrome. Similarly, plasma exchange has also been utilized for patients who develop Guillain-Barré syndrome. Combination of ganciclovir and immunoglobulin has been recommended in patients of bone marrow transplant and patients with the who have developed CMV pneumonitis. So this was an overview of the respiratory infections. Now there is another group of viruses which can come into the ICU. They are the CNS viral infections. Among the acute viral infections is the rabies, enteroviridae, mumps, arboviruses, then herpes like the HSV, VZV and CMV. This is another group of viruses for which a patient can come into the ICU, and of course the Japanese encephalitis virus and the measles, they can also come into the ICU. They can cause encephalitis, meningitis, myelitis, Guillain-Barré syndrome and post-infectious acute disseminated encephalomyelitis. The treatment in these patients is the early administration is the key. Out of these, HSV encephalitis, if you suspect and if you treat these patients early, they have a very good outcome. Treatment of HSV encephalititis is a high dose intravenous acyclovir which should be administered as early as possible for 14 to 21 days. VZV encephalitis, use acyclovir for up to 3 weeks is recommended for severe infections like encephalitis. Fosacarnet has been recommended for HHV6. Combination therapy with fosacarnet and ganciclovir has been recommended for CMV encephalitis. The use of antiviral is limited in non-herpetic viral nervous system infection. The drug like plecanoril is an inhibitor of viral replication and has been suggested to be tried in enteroviral infections. Like any other viral infection, supportive therapy is the mainstay of the treatment of viral nervous system infections. Neurological and infections and their systemic complication, they may exacerbate brain damage, should be identified and treated early with the supportive therapy to optimize the neurological recovery, because this is the most important treatment of these patients. Then I will talk about the viral hemorrhagic fever. This is another group of viruses which can present, and they have resulted in a lot of mortality all over the world. Dengue virus, which is present in the Asia Pacific region, and it is a dengue hemorrhagic fever and dengue shock syndrome result in lot of deaths because of these infection in certain individuals. We have discussed already in the tropical module, so I will not talk about in this. But viral hemorrhagic fever can also occur because of the other viruses like the Ebola virus, Crimean Congo hemorrhagic fever, or what is called the CCHF, hantavirus, Lassa virus. When you have these viruses, the IVIG may be of value in the Lassa virus. These viruses are very infective. You require strict isolation procedures. Adherence to guideline is very, very important. Personal protective equipment should be there, and there should be proper training of putting and donning under observation, and appropriate waste disposal should be done of these viruses, because these viruses are associated with very high mortality. Then virus can result in a viral myocarditis and cardiogenic shock. Coxsackie group A and B viruses, they are one of the common viruses which result in the viral myocarditis. Predominantly it is the enterovirus 71, Coxsackie, ecovirus, then of course the influenza, adeno, parvovirus, RSV, hepatitis A and C, vaccinia viruses, all have been associated with causing the cardiogenic shock and myocarditis. The treatment of these viral myocarditis, of course you can give antivirals and the supportive treatment, but there are some specific, if you isolate a virus, you can give those antiviral treatment, like you can give rifampin for RSV myocarditis, plecanoril severe enterovirus infection, or oseltamivir for severe influenza infection, the antiretroviral for HIV-1, and steroids, they have not been shown to reduce mortality in viral myocarditis, should not be tried. So the treatment of viral myocarditis is supportive, and if you isolate a virus, you could give antiviral treatment to these individuals. Then, as I said, this can develop the gastrointestinal outbreaks, and the rotavirus is the most frequent viral agent which has been associated with the viral gastrointestinal outbreaks in the ICU. The viral infection can also present secondary to acute viral hepatitis with acute liver failure, and which can result in a hypovolemia and distributive shock. Hepatitis A, B, C, D, E, G, and herpes group like the CMV, HSV, and Epstein-Barr virus, which are part of the herpes group, adenovirus and influenza virus, they all have been implicated. Treatment is basically the hemodynamic and supportive treatment, and you have to manage acute liver failure and associated organ failure, and these patients, the outcome of acute liver failure has really changed after the liver transplantation, and if wherever indicated and possible, liver transplant should be done in these patients. Then there are special immunocompromised hosts like trauma and burn. These get infection with HSV and CMV. Supportive, antiviral and steroids is the treatment in these patients. The pregnancy, HSV, varicella zoster virus, CMV, influenza virus has been reported to cause infections. Treatment is again supportive and antiviral. In transplantation, of course, in a patient who's got a transplant, the CMV is one of the very common viral infections. Epstein-Barr virus, varicella zoster, HSV, HHV6 and RSV, influenza A and B, adenovirus, all have been implicated in these patients. But of course, out of this, CMV is the commonest organism which have been shown to cause infection in these individuals. The treatment, of course, supportive, and you have to give antivirals. And then there are a lot of experimental therapy have been tried, but they have not been found to be really effective. Infection control measures should be followed in all patients who develop viral infections. They have a major role, and the primary factor responsible for transmission of viral infection in the ICU is basically the lack of the training and compliance among the caregivers and infection control procedures. So one has to follow these, because otherwise a lot of patients, the healthcare workers, will get infected with these infections. If patient is in the ICU, the use of nebulizers, the non-invasive ventilation, disconnection of the ventilation, the endotracheal tube suction, they all can result in the spread of viral infection in the ICU setting. So infection control measures should include airborne droplet and the contact precautions, and disinfectants are highly active against many viruses, so one should practice the hand wash and other practices which are nowadays suggested to control the infections in the ICUs. In the end, I'm going to talk, as I said, cytomegalovirus, although it is a very common virus, because there is a rise in the population of transplant, the renal transplant and the liver transplant, and this is one of the common virus which we see, and one needs to know how to manage these. The cytomegalovirus infection and disease, these are two different terms. A person may have infection, you may isolate, he may have a CMV replication, but may not have symptoms or signs, and which doesn't require treatment. A CMV disease is defined as evidence of CMV infection with attributable symptom and signs, which may manifest as either a viral syndrome or a tissue invasive disease. Viral syndrome could be fever, malaise, leukopenia, thrombocytopenia, or a tissue invasive, depending on the organ involvement, you will have symptoms. Is a common infection, and serious disease is rare in a immunocompetent patients. As I said, it could be isolated in immunocompetent patient, particularly in certain individuals who have been in the ICU for a long time, but it doesn't cause serious disease in them. But in immunocompromised patients who are like solid organ transplant recipient, the hematopoietic cell transplant recipient, HIV infected, and patient treated with the immunomodulating drug, these are the 4 or 5 groups of patients where you see a lot of CMV infections. It can result in a febrile syndrome, it can result in hepatitis, pneumonitis, retinitis, encephalitis, esophagitis and colitis. The symptoms and signs of CMV disease may overlap with other infectious process. So you really, sometimes it is very difficult to differentiate in a transplant patient whether it's a rejection or it is the infection. So you have to make a diagnosis based on a clinical history, presentation and the laboratory data. You make a diagnosis. What are the diagnostic modality? Of course, serology, qualitative and quantitative polymerase chain reactions, PP65 antigen detection, culture and histopathology. These are the various options you have. The serological tests have really no role in immunocompromised patients. They could be useful immunocompetent, the rise in the IgM level or the 4-fold rise in IgG, which could be a pointer towards infections in immunocompetent, but really they have no role in diagnosis of infection in a immunocompromised patient. Quantitative PCR test and the CMV PP65 antigen detections. These are the tests which are nowadays used more often to detect the CMV infections. Quantitative PCR has a lot of advantages over the antigenemia assay, including better assay standardization, increased stability of the specimen, smaller specimen volume, and the ability to test patient with leukopenia. So these are the advantages of the quantitative PCR assay. So quantitative PCR assay is more likely used nowadays as compared to the antigen detection. Patient with a CMV disease will have a significantly faster rate of increase in the CMV load, which you detect by the quantitative PCR assay. Quantitative PCR assay will detect the wider viral load. So the CMV disease patients will have a significantly faster rate of increase in the CMV load between the last PCR negative and the first PCR positive. Of predicting CMV disease, and more than 5,000, the sensitivity is 86% and specificity 87% about the quantitative PCR assay. Not only is the level of CMV load is predictive of the symptomatic disease, but also the rate of increase can also use to predict which patient are at a risk of CMV disease. In one study, patient with CMV disease had a significantly faster rate of increase in viral load between the last PCR negative and the first PCR positive than those without disease. So the rate of rise can also tell you that whether it is a disease or it is just an infection. So once you have decided the patient has infection and you started treating, then you must do the CMV viral load PCR, quantitative PCR every week, because it should become negative once a person has responded to the treatment. Patient who have a persistently high viral load, or there is increase in viral load, or there is a rebound, that viral load came down and again rises, this is an indicator that patient has a drug resistance. And resistance is tested using automated sequencing method directly from the clinical specimens. CMV culture usually not done, but they lack the sensitivity needed to diagnose CMV associated viral syndromes. Then the tissue invasive disease. The gold standard for diagnosing CMV tissue invasive disease is the identification of CMV inclusions or positive CMV specific immunohistochemistry staining on histopathology. A positive culture from a biopsy specimen is also considered consistent with the CMV disease. A person, if he has a negative plasma and a whole blood PCR, it does not exclude the invasive CMV disease, especially in patients with CMV gastrointestinal disease, pneumonia or retinitis. These patients can have a negative plasma or CMV, but will have a positive tissue invasive CMV disease. Yes, for pneumonitis in transplant recipients, the identification of CME inclusion in cell obtained from the bronchial lavage or lung biopsy support the diagnosis of CMV disease. A positive culture is often difficult to interpret since CME is commonly shed in the respiratory secretions in the absence of disease. For GI disease, plasma or whole blood CMV DNA load tests are sometimes negative. So the diagnosis relies upon culture and histopathology of a tissue biopsy. GI disease may be focal and patchy, so multiple biopsies should be obtained in these individuals. For CMV encephalitis, myelitis, polyradiculopathy, viral load testing of cerebrospinal fluid has become the standard of care. So when you give the treatment, you should keep on doing viral load, as I said earlier, and CMV loads should be negative, and then you should give a maintenance doses. Resolution of viremia is proven with 1 or 2 consecutive negative viral load assay, ideally 1 week apart, indicate the person is cured. CMV infection, as I said, occurs in immunocompetent adults with critical illness, usually appears due to reactivation of latent infections rather than the primary infection. and it can vary from 1 to 35% of in 1 to 35% of patients. All studies have shown that CMV reactivation as measured by CMV viral load, even in these immunocompetent individuals, is associated with prolonged hospitalization and death. Now, how to treat these? There are 4 drugs: ganciclovir, ganciclovir, fosacarnet, and cidofovir. Ganciclovir is available intravenously and orally. Bioavailability is oral ganciclovir is poor as compared to the IV, and recently it has been replaced with the oral ganciclovir, which is well absorbed, rapid converted into ganciclovir, and it has a good bioavailability. The oral ganciclovir 900 milligram can achieve similar systemic exposures as a standard dose of intravenous ganciclovir. In a patient who's got a retinitis, intraocular injection of ganciclovir plus systemic ganciclovirs are indicated for the treatment of immediate life-threatening CMV or the sight-threatening retinitis. Ganciclovir and ganciclovir are associated with bone marrow suppression, leukopenia, low platelets, so one has to be very careful, which can usually be managed with the hemopoietic growth factors. Dose adjustment is required in a patient with impaired renal functions. So, to summarize, patients with severe viral infections are often hospitalized in ICU. It can cause severe morbidity and mortality. Newer diagnostic tools have helped in identifying viral infections. The mainstay of therapy in viral infection is supportive care. Antiviral therapy is available for limited number of infections, including influenza and herpetic infections. Novel antiviral treatment strategies undergoing research, and that is the need of the day to improve the survival in these patients. Thank you.